Hello, good evening, good afternoon to everyone. Thank you for joining us again for another interesting and fascinating presentation. We are continuing our focus on Embalmers Clots. Now, why am I continuing to talk about this? Well, for one, ever since a whistleblower came out and showed clearly that we are seeing these odd patterns of clots occurring in living people, I knew this was extremely important. The whistleblower took a great sacrifice and risk to speak about this. And so, my responsibility since he came to me is to continue to raise awareness until thorough research has been done. Tom Haviland, who has been pushing this and asking for further research across the world, he continues to raise awareness. My job is to keep our focus on a really critical question. And so today I have another person speaking out. And this is important because this is our first medical person speaking about some of the unusual things that he is seeing. Other people have indicated in the past that they would have thought about speaking out about it, but most people are afraid. That's the reality. It's not being heard about because the clinicians, the ones who are willing to talk about it, recognize that this could have serious implications to their professional work. That's very sad because the science still needs to be explored. Now, what I've got today is that I've got Dr. Phillip Triantos and Dr. Chetty, and we're going to be exploring some of these ideas in a little bit more detail. Before we start, let's just bring them in. So, Philip, how are you? You've got a great name, something I wish I had.
I
So
think
we'll start off with you. Just give us an introduction of yourself so that
yeah,
we.
absolutely. First of all, I'd like to say thank you for having me on. It's an honor to be with you guys. Dr. Chitty, I followed your advice early on. And with the help of you, Dr. Pierre Corey, Dr. Paul Merrick, and Dr. McCullough, y'all saved a lot of people on this side of the world, number one. So I appreciate that. And it's an honor to speak with you guys. Yeah, it's an interesting story. I am a radiologist. I did interventional radiology for about 25 years. When the pandemic hit, of course, I knew something was different than other viruses that attacked us because it was affecting every system that you could imagine. And then I was wondering why, as physicians, are we not trying to find a treatment? Why are we waiting for a vaccine? And I knew just from my basic knowledge that you don't treat a viral pandemic with vaccines. And so you want to treat the illness. And so that kind of got me out of my wheelhouse and uh, started studying and reading and listening to physicians like Dr. Chetty and everybody else. And night and day, I mean, I literally gave up my radiology practice, the majority of it, to figure out what was going on. Number one. Number two is figure out how to treat these patients that were suffering and calling me because they had no one else to call except a limited few. And so I decided, what's more important in my life is to, continue in my career or to save some lives and do the right thing. And so I decided to branch off and become a clinician again after all these years. So
Excellent. So listen, we'll get Shankara for people who don't yet know him. Just give us a brief introduction of yourself, Shankara.
Thank you, Philip. Pleasure, Dr. Triantos, to meet you. My name is Dr. Shankara Chetty. I'm a natural science biologist and a general medical practitioner running a private practice in Port Edward, South Africa. I've treated COVID from the start of the pandemic and, of course, having to deal with all the mismanagement of COVID subsequently. And so, I'm looking forward to this discussion.
Excellent. So just so that people understand what we're doing, is that we've got here Dr. Triantos, and I've got that right, haven't I?
better than I can say it, yes.
So, Philip, so we've got you here. You're a radiologist, and I think that it helps people to understand a little bit about why is it that your profession is so important in the context of observing a lot of these abnormal clots, because we don't know it exists largely outside of your kind of work. What is it that you guys will tend to do that will highlight these clots that make us need to treat them with embolectomies?
Well, first of all, yeah, I look at a radiologist as like we're the air traffic controller, right? I mean, almost any patient will get some kind of imaging exam. So I can play a part in that. And when it comes to this issue, we can find these clots, whether it be by Doppler ultrasound or, a CAT scan or an MRI, whatever the modality is. And so that's where our role comes in. Now, actually, in the beginning of the pandemic, we formed a group of doctors here in Birmingham, Alabama called Concerned Doctors. And I worked with a few of them. And what we did was, since we knew that people were clotting, I had the clinicians send to an imaging center so we could evaluate early for the clots. And unfortunately, in the number of patients that we looked for these clots, we never saw any clots. They would probably at the microscopic or level and so we were missing those clots until they propagated and got bigger, and then later on we would see the clots. So at this point, over the last 2 or 3 years, I'm seeing more and more heavy or large clots that are macroscopic that we can see with our eyes. So that's where we play a point, and then of course we can lead the clinician, say, for treatment. Now, unfortunately, the treatment is the old treatment that clinicians are used to, and not what we have learned to use to break down the fibrin and some other things that go along with that clot. So
Yeah, and just so that the audience understands, is that regularly when we're looking for big clots, we usually have the radiological scan where they usually give them contrast injections to almost light up the blood vessels, and therefore then we can see where there are any big clots located and whether or not they need to have urgent treatment. So radiology is an absolutely critical part of clinical medicine, especially the interventional part that you used to do in the past, Philip, but you're not actively doing at present. It's other aspects of it. Shankara, before we step on, I just wanted to pull you in. Any thoughts at this moment? Because what I'll be doing next is focusing on why Philip stepped out of the radiologist scene and became almost back to basics of being a doctor again. But any thoughts so far?
I think, I think, Philip, when we look at the clots that we're dealing with, we know about the microvascular clotting that we've seen, and it creates ischemia that's difficult to diagnose because you don't see the cessation of flow. Patients got good pulses, but they've got symptoms of terminal ischemia. Now, with those clots, they're very different from the Embalmers clots that we saw. The composition is completely different. So when you look at these microvascular clots that coagulate into bigger clots, they are typical clots. But when you look at the Embalmers clots that we're seeing, there's fibrin deposition in them. And when they looked at the composition of those fibrinous structures, there wasn't the typical blood products in them. So there's two different mechanisms going on. One might be related to the immunology that the vaccine triggers. The second might be related to the lipid nanoparticles and the other constituents of the vaccine. And that might be triggering a separate process. Because the Embalmers clots were actually bigger in those patients that took more vaccinations. And that might be the
Yes,
reason.
yes. So yeah, that's certainly true. And just a curious question here now, Philip, that I think is very important. Early in the pandemic, you said you stepped out of the radiology to actually then start trying to treat patients. Now, there'll be some clinicians who would criticize you for that, meaning that a radiologist should stay in their lane and only do radiology. What are your thoughts on that?
yeah, absolutely. Two things come to mind. Number one is I am a physician. I'm an MD. I trained at a major university. I after my medical degree, I did a year of surgery and medicine, and then I eased into my radiology residency, and that was a 4-year program after my first year of medicine and surgery. But during that time, I never quit becoming a physician. I always treated my interventional patients, always read the charts, always looked at their values before I did any procedures. I took care of the patient. So I was very familiar with treating care of the patient. And so when this pandemic hit, I had the capability of doing my own research, studying people like Dr. Chetty and other doctors that I've mentioned, more so than probably most of my colleagues who actually stayed in the lane. And that's where I am able to treat. I feel like I've had the experience. I've never quit being a physician, except if you ask my children who don't think I'm a doctor because I'm a radiologist. Other than that, is I've always, I mean, that's inherent in me, is to take care of people. And so that was easy for me to figure out, what treatments were available at the time. And we were all learning. And so there's my answer. I think I'm just as capable as the next doctor. I started from ground zero just like they did, because it was all new to all of us.
Excellent.
And I probably hit it a lot harder than most.
Yeah, and it's an important point, Shankara, because you as well have had criticism about the fact that you're a family physician in South Africa. Why should you be able to know more about treating COVID than somebody else? Now, they've forgotten the fact that your outcomes have been remarkable. Nobody died under your care. What are your thoughts on that?
I think the same, Philip. You need to be able to get out of your lane. Medicine is a field that covers everything. And so you got to keep up to date with what's going on. I've had the same like Dr. Triantos, but in the opposite direction. I've been told not to play in the poppy field and go manage the gate like a GP is supposed to do. And I think, each one of us have different experiences through life. And I think we gain different understandings. And that is where I've said previously that it was the doctor's lounge that brought all the benefits, and we've stopped doing that. And with the pandemic, if you look at what really transpired, it's doctors like ourselves that have tried and spoken to each other, learned from each other, that have made the difference.
Absolutely. And I think that this is the important lesson. When I look back at all the research I've been doing, one of the clear things that has come across to me is that if you try and put COVID in any specialty, there is none. It has elements of infectious diseases, has elements of virology, it has elements of autoimmunities, which is immunology and rheumatology. It has elements of vascular. It is extremely broad. And what's very interesting is that the people who have the broadest thinking on medicine tend to be in a much better position to try and understand the disease, because they are not limited in their thinking by any specific specialty. Any thoughts on that, Philip?
Uh, you know, I think it basically comes down to the individual, and I, I'm not so sure if I think there's individuals like me and Dr. Chitty in all fields and all specialties, and I think we all know some physicians that will stick to the advised protocols, that will stick to what these journals have told us all these years. And I probably am guilty of that until the pandemic hit. And so I think it's not, I think it's spread amongst all the specialties, but it's individualized. And I don't know why I figured out early that something was a must and I needed to get out of my safe place and go do what I needed to do. And I don't know the answer to that. I really can't. I don't know. I don't know what caused that. Maybe I do believe, like Dr. Chetty was. I've seen him speak before, and I think it's it's a spiritual thing. And I'm a firm believer in God and Christ, and I think I was touched to do this. I mean, I think that's my hill to actually die on. And I sat my wife down one evening and said, when I started learning this stuff, I said, I can't even explain what I'm reading. I can't even get it out how serious this is and what I have to do now. And so I think it's just individualized. It's just in the person. I mean, I can't explain it scientifically. Dr. Shetty can help me out there, but
It's an interesting point, Shankara. Thoughts on that?
Yeah, I think Philip, you're absolutely right. For myself as well, I knew that there was something nefarious going on. I knew it's going to be a threat to my life. I knew that I'm going to be taking on the World Health Organization and big players. I could see the agenda from the start. But given that choice, it was let's call it a leap of faith. I knew I had to do it. And yeah, I think it was a spiritual journey for myself as well. I sat down with my wife and I explained to her as well that I'm going to have to do this. My son and my wife were afraid. I moved out of my home. I stayed away for 4 months. But one day I sprained my ankle and I couldn't go back to my flat. And my son came and sat next to me and said, "Nobody's died in your hands. Why are you afraid to stay at home?" And so I moved back into my home. And that changed it all. So it was the fear. But I think those of us with a fair amount of faith looked past that fear and did what we had to do.
Absolutely.
So, bringing us to the meat of the matter, so to speak, I'm going to, before I show this image, I just want to let people know that if you are squeamish at this point, just for a few seconds, please look away now, because I'm going to show you an actual real live clot. Okay. So if you look away, I'll show you this quickly. I was sent this today by somebody who again is sharing. This is what was pulled out just a few days ago, and this is the kind of thing that they're starting to see on a regular basis. And so what you can see here is that I think that the concern is this area here. These are the white parts. The dark red part represents a normal clot, but you can see this in it, which is the fibrous bit that many people are talking about and that the whistleblower had seen as well. So it's a combination of stuff. Now, when we see this is a big clot, and Philip, you will see this on a radiologist scan, won't you? So this was probably taken from the inferior vena cava going down, and so that would stand out as a massive clot on an angiogram. You've always seen that. What's different this time?
Well, I can't explain it I wish I had my pictures. Are we good to go with my pictures? Okay.
Did you send them to me?
We sent them to you.
Okay, don't worry. I'll pull them up. So yeah, keep talking.
Well, I think that what we're seeing is, I was used to seeing a clot that was more like a jelly consistency, right? A jelly. Actually, you could crush it up in your hand. And these clots, as you know, you're not able to do that. And, the makeup of them, I'm sure y'all spoke about it with Richard Hirschman and Thomas Heavlin recently. But they, to me, are more bright on the ultrasound, okay, or echogenic is what we call it. But and these large clots like you're looking at there, of course, they'll fill the whole lumen and you don't have any blood flow. Now, in my 30 years of experience, other clots, the jelly-like clots can fill a whole lumen and occlude a whole vessel, but it was usually not as extensive. Number one, I mean, it's just, I would rarely see a clot that extensive, what you just showed, Yeah. So, I'll go ahead.
Yeah, I was just saying that this is the problem, is that many people may see this and think it's anecdotal. What would make you think differently?
Well, radiographically, there is an overlap, unfortunately, because if you have a chronic blood clot in your body, it'll tend to become bright and echogenic, but the blood vessel will usually shrink if it's a chronic clot. Well, these do not shrink the blood vessel. They will actually, after they expand so much, they'll keep them the same size or possibly enlarge it a little bit. So that is one thing. And just the sheer numbers of clots that I'm seeing over the last 2.5 years, just the volume, it's just been unbelievable. And my colleagues, I'll call around and ask them, are you seeing the increased clots? Yes. Are you seeing an interventional specialist? Are y'all, now that I'm out of the business, are you pulling out white clots? Or yes, they're white and blood, then red, so they're seeing it as well. So, I mean, the evidence is there. And, I never saw it before, the pandemic, or actually before 2021, let's say. So, and I've been doing this for almost 30 years. So
this is important. So Shankara, As I brought you here specifically because you were with me when we had that first whistleblower, and I was stumped at what he was showing. And similarly, with what Philip is saying here, this is a problem. Why is it that, from a medical point of view, the system is almost complicit in ignoring this? This is the bit that I'm trying to get my head around, because Philip mentioned it there. They are seeing it, they are acknowledging it personally, quietly to one another, that they're seeing it. But everybody is afraid to talk about this. What do you think is going on, Shankara?
I think, Philip, we're seeing, for all the people seeing this, it is a completely unknown, unseen pathophysiology in the human body. And of course, we as doctors want to explain what's causing it. So if it's something that is completely new to humanity, then we've got to look at what else is completely new to humanity and no one wants to look there. And well, best we be silent about what it might be. So yeah, we've got a completely new type of clot that they haven't seen before. So I think there are people that are afraid that I think they're at the back of the minds, they know what triggered this. And yeah, so like we're getting doctors not wanting to come out to rock the boat, they know that seeing these kind of clots is going to rock the boat.
Yeah, and Philip, you know from personal experience, because you had to think very hard about speaking about this.
Oh
What
yeah.
eventually made you take that step?
Well, someone asked me to talk about it, and I was hesitant about getting in the public eye. I mean, I would tell my family and my friends, but I made a decision that if I don't speak and nobody's speaking, where are we going to go with this? And even amongst our doctor group, we would have meetings weekly, but we would never spoke in public. And finally, it was February of 2022 is when I finally got in public, and I actually had to have armed guards, police officers outside the door because I got threats before I went into the venue to give the talk. And so I think that plays a part in it as well. And then, of course, as we know, the financial burden on the physicians. And I can excuse all that. Maybe the first few months of this catastrophe is what I call it. But now there's no excuse for any physician. I mean, it's just there's no excuse for any physician not to be speaking out about this. I mean, this is nothing hidden anymore. I mean, the data is overwhelming. The papers are overwhelming. The composition, of these rubbery clots that we've never seen before. I mean, you can't be silent anymore. But I stood out. I took that step because I knew it was the right thing that I had to do. And I mean, I just couldn't sit by. I mean, I didn't want to go public. I'm not a public person, but like every time I want to pull back, here I am again. I'm talking to someone else, but you know what? We're getting the word out. And so that's the most important thing.
And it raises a point. I usually use this example, Shankar. I'll put this to you, where it's. I think that the clinicians are in a difficult position, because if they don't come out and speak about this, and then this is an issue down the line, they appear to be complicit. But if they do come out now and say something, they can be targeted, and they almost have no skin in the game. Why the silence?
I think the skin, like we said, Philip, the skin they have is their egos. And yeah, I think we need to get past that. At the end of the day, we've all made mistakes. If you want to accept that a mistake was made, then you got to look back and figure out why you made that mistake and understand that you were coerced into doing this without any scientific proof. You'd have to really look at where you get your trusted information from. And so, yeah, it's a complete realignment and reassessment of you as a doctor in totality. You've remember that I think they've co-opted the medical fraternity, because we're the only fraternity in the world that can legally give someone an injection that's toxic. And so if they had this agenda to give a toxic injection to the population, well, many years ago, they started to co-opt and coerce the medical fraternity into doing exactly what you're told, or you'll be suspended. And that's where we are today.
And I think a part of it is this as well, is that the physicians that stood behind these vaccines so strongly, and I think some of them are still blinded to the facts. They don't want to believe that there's something that they gave someone that actually damaged them, you know. But I think there are those that do know that it caused damage, especially like you just saw in the UK, AstraZeneca. All these public figures are now just coming out with how much money they've gotten paid behind the scenes to be public about it, to advertise it. I don't know their names, but I saw the report. So I think it's twofold. And the medical science was not there. I mean, I was told, I've spoken about this publicly, I have pulmonary artery hypertension, and I was being seen at the major university down the street, and I survived a bout of COVID, and I knew that if it went into my lung and it hit me with the cytokine storm, I would probably be dead, because I was already in failure. Okay, I was already on Lasix. I was in trouble. And after I survived that event, I asked the ID doctor at the university, and he's about the so-called vaccine, and he said, yes, absolutely, get it. I said, why would I get a vaccine? I just had a virus. Then we know that my immunity is probably good for at least some time. He says, oh, well, it'll help it a lot more. There was no data to show that. My cardiologist at the same university said the same thing. Go ahead and get vaccinated. I already knew about myocarditis, was already spoken about. And so it's egos. Okay. I think that's a part of it as well. So it's complicated. But again, I'm to the point now where I don't think anybody can be excused any longer. I mean, there comes a point in time where if the data wasn't there, if the studies weren't there, then I would say maybe, but it's all there. So there's no excuse any longer.
Yeah, those are some heavy words there, Philip. And I think that at the moment, with what we are seeing, you see, part of the problem with the clots here, and I'm going to, again, if you're squeamish, just look away for a second. I'm just going to show you. I can't get your slides up, but I know you're going to show me something like this, Philip. So again, this was sent to me recently. Again, this is significant. These are the pulmonary arteries here, and these are the clots, so this is bilateral clots, not quite a saddle embolus, but significant clots that are occurring. And this was pulled out of somebody just I think in the past week. And this is happening all across the world. Now, people think that this is just about arguing about conspiracies and so on. But I'm thinking about this very practically, because this is going to have implications for people who are on anticoagulation, who are at risk for clots. If we are seeing a transition with the way how clots are forming, we may need to be using different combinations of anticoagulation. We may need to combine antiplatelets with anticoagulation. We may need to do all kinds of different things. But the reality is that it makes the research that we had done previously null and void. And the longer it takes the medical fraternity to examine this and to understand it and to figure out how to mitigate it, the more harm that is done to the population. Any thoughts?
I agree with you, and there's definitely a delay. I'll give you an example of a patient and a friend of mine who I've treated for COVID several times. She's been vaccinated, I believe, twice. She just recently had a bout of COVID, and her physician, who's an internist, told her, well, they told us, these are almost quotes, I'm paraphrasing, but almost exactly. They told us that there is a thing called long COVID. Okay, this is an internist here in the city. However, they didn't tell us how to treat it. Okay. So as a physician, I'm going to sit around and watch this patient suffer and not find out for myself, figure out how to treat it. But while she was walking out the door, he asked her, would you like your booster today? So there's a disconnect somewhere. I mean, and I can't figure that out. I mean, it makes no sense to me. And I wish we could show some of these slides, because I have unfortunately a great case of a saddle embolus that we could see in a person?
What you have to do for me is if you can get somebody to send it again I need access. This is a problem. It won't let me get access. But if you can get it sent again
Can you send it to this
without
computer?
you actually, if you can show me, just click present on your computer and you would be able to show me it's just that you wouldn't be able to see at the same time. That's the only thing. So it would show the
I'm on a backup laptop because we're having the trouble with the first one. So I'm going to get him to send it to this backup laptop, and your viewers will be fascinated what would like to present to you guys, because that's the other thing is, I mean, I'm seeing it daily, every day. Last night I was reading and a blood clot, and that's not where it stops. I mean, like we said about every body part from head to basically toe. I'm seeing all kinds of disease processes, female reproductive issues every day. I mean, before I would see maybe, I use this example, I'd go 1 or 2, 3 months before I'd see a miscarriage, right? First trimester miscarriage. Now it was to the point I'd see 3 or 4, 5, 6 in a week. My histories are like this now. Postpartum bleeding. And if I read 10 GYN cases, 6 or 7 are going to have to do with postpartum bleeding or irregular menstrual cycles or antepartum bleeding during pregnancy. I mean, that never used, I mean, it was very rare for me to see these, right? Now I'm seeing them daily. Cancers. I just had a 45-year-old guy who got the jab 3 times, presented with a dull headache, and he's got a big brain tumor. I'm seeing cancers. I just talked to a colleague of mine here in the city who's a concierge physician, and he's an endocrinologist by trade, and he has seen 6 cholangiocarcinomas in the last 3 years. 6, which he's hardly ever seen before. A friend of mine is an oncologist here, and he says the numbers are definitely elevated. So the evidence is all around us. The insanity has got to stop. These other clinicians has got to get on board. And I can go on and on about doctors within the hospital telling us what they see, but we've got to get on top of this.
Thoughts, Shankara?
Yeah, Philip, it's absolutely obvious that we got problems. Just from my personal experience, I've got 2 family friends that passed away with sudden cardiac arrests. One at 35, an attorney, and an advocate that was flying to, I think, Hong Kong for a legal conference, and 15 minutes into the flight had a heart attack. He was 44. I've got a cousin of mine who's 48 who suddenly got diagnosed with the breast cancer. It's now stage 4 within 2 months. I've got another cousin of mine who had a rash on her chest, and within 4 months it was diagnosed as severely metastatic stage 4 breast cancer. And within 4 months of diagnosing it, she passed away. So every one of us knows someone that's had something very unexpected happen to them, or demised very unexpectedly at a very unexpected age. So yeah, we're not counting the numbers, we're not looking at any causality, but I can guarantee you the numbers that we're talking of when we look globally are far less than the true effect of what's going on. We have influenced negatively the physiology of the entire planet. And the medical textbook can be thrown out the window, and we have to start from scratch again, because the vaccines altered our immunology, and everyone is now going to respond to everything differently.
Absolutely.
I mean, everything.
Yeah, just like you said it before, it's the dysregulation of the immune system. I mean, I've been sick 3 times in the last 2 months. I mean, I get well for a week or so, then boom, I'm sick again. It's destroyed my immune system. That's just from COVID. I mean, having it 3 times. So both of us. I mean, whether you're vaccinated or not vaccinated, we're all in this together. And like you said, we got to start from the beginning. I mean, we got to figure out how to get more scientific and learn more. And of course, the treatments. We're working, and I work with. I don't know if I work with local doctors here that are on the front lines. Dr. Jordan Vejon, who's been on top of the vascular issue, and Dr. Diane Counts, who's a neurologist here in the city, and we're not giving up, and we won't give up. So,
yeah, it raises one of the questions that we were discussing when we spoke to the whistleblower, and I just wanted to capture your thought on it, Philip. Is it can't explain why it seems as though some of these abnormal clots are forming, especially in the big venous vessels, the inferior vena cava, the pulmonary veins, and so on. And it seems as though they are not visible initially, because we do angiograms all the time. And this kind of clot can't just appear out of nowhere. So it must be there. How is it possible that it's not being seen?
Well, I think it's twofold. I think that it's like we talked about the microvascular circulation. Okay, so it's got to start. Most of these patients are very hypoxic in whatever part of their body that's affected. So we start at that level, and then if we can get these slides to show, I have a progression of where we see a little clot and we see a little bit more. So these clots that Richard probably had showed y'all were how some of them totally occluded the entire lumen of the vessel, right? So it took time to get to that level, maybe 6 months, a year. But as that was forming, blood was still going through the lumen that was open until it reached its maximum occlusion. So I think the symptomatic patients that we get to early enough, and then you have the patients that are not really symptomatic until it's too late. Like they're still getting their blood flow through enough of the lumen, and then in the last process, when it closes down completely, then becomes symptomatic, and then that's sometimes when it's too late, and then you have them in Richard's facility. But just the spike protein hitting the endothelium, and we know all the sign, what we know of it so far is that, so it starts on the lumen wall. I mean, autoimmune. I mean, so the list goes on what's causing these things, but anyway, so I think it's a progression. I think we can start at the microscopic or level, and then I think, as some of my slides will show, if we can get them up, that you can actually see the propagation of this stuff to where then it completely occludes the lumen. So,
and Shankar, you had mentioned something about casts. Could you explain what you were thinking at the time, and let's see if Philip has any thoughts on it.
When I look at what we're seeing with the clots, we're seeing a mixture of the fibrinous and the traditional clot, right? But when you look at the fibrinous clot, it tends to be one long strand, and you've got clots attached to it, natural clots attached to it. So you've got two processes, Philip. You've got the fibrinous structures that are forming, and you've got those fibrinous structures causing turbulence in blood flow, which actually causes normal clotting around it. So what I think is happening, if I had to put it into a framework, a little bit of understanding, I think that imagine a streamer in the lumen of the vessel, and it's not occluding blood flow, but it's stuck to the vessel wall, and that streamer is growing. So what happens is you've got some process that's on a nidus on the vessel wall, triggering a process, a catalytic process, that's going to cause this fibrinous clot to constantly elongate. As that fibrinous clot elongates, it doesn't occlude the lumen. It's flapping around like a streamer in the lumen wall, and the blood is flowing past it. So you don't see it. It's there, and it keeps growing. But it keeps causing more and more normal coagulation around it. And the longer it grows, the longer the clot. But it hasn't occluded the vessel. And because it needs this turbulence to have coagulation around it, it will occur in slow flowing areas of the body and in vessels with bigger lumen with more stasis of blood. So in the venous system, in the bigger vessels. So as this fibrinous clot grows through a polymerization process where it keeps getting proteins from your system sticking onto it and growing it, it also acts as a foreign body in the vessel, creating turbulence. And it's that turbulence that causes the blood to start to clot around it until eventually the pressure cannot push through and it eventually just blocks up. So depending on when it blocks up, you can get a short strand of it, or you can get a very long, like they're pulling out 2 feet clots from patients, leg veins and things like that. So it couldn't have occluded at a short piece. It had to be a 2-foot clot that was still allowing blood flow through for it not to have been detected at 2 feet.
Right, exactly. And the polymerization is the key, and that the contents that are in these clots are not normal blood products, as you know.
And when you look at the polymerization process, when they looked at the content of the fibrinous clot, they found a lot of things that weren't normal constituents of blood. You didn't find the high levels of ferritin and things. But one thing that they found that was strange was they found a high content of tin. They found a spike in tin. Now, if you look at tin, tin is used as a catalyst in the making of PVC pipes. And so all our water supply is PVC pipes. And so a lot of people have tin in their system. So tin being a catalyst, and of course in the lipid nanoparticles, you've got phosphates and sulfates, which actually act as polymers as well, catalyst to a polymerization process. So all you need is one trigger event on a vessel wall, and all the proteins in blood act as monomers. And this is a magnet for them. And they keep sticking on. And the end of them is always sticky, and it sticks another one on. So it's like putting a drop of catalyst into fiberglass. That one drop just spreads and hardens the entirety. So you got this one fibrinous structure growing inside the vessel through a polymerization process. And when you look at it, the polymerization process creating the cross-linking will give it its structure and elasticity and its tenaciousness, because it's not just stuck on, it's cross-linked on, like polymerization does. So if you look at the fibrinous structure, you'd say it's almost like polyurethane forming in the center of the vessel. But because it's flapping around as blood flows past, it's creating a nidus for normal coagulation to take place around it until it eventually just blocks up.
I love that description by Shankara. Now, just think about it a minute, Philip, because we're kind of like having a brainstorm on it. Is it possible that some of the things that you would see in standard angiograms that you may assume is plaque on the vessel wall could be this kind of polymerization process? And is there anything that could be different that would make it be able to be more easily identified so we would know who could be being affected more? Any thoughts?
Well, since I'm not doing any interventional work in or angiograms anymore, and most of my diagnostic tools are, ultrasound or CT or MRI, I really can't answer the vascular process with an angiogram. However, I do see, different different forms of the clot, which could exactly explain what Dr. Chetty explained in his unbelievable description there, because that seems to be what's occurring is how you get these long clots and it's not completely occluded, and then finally the turbulence around and then slow flow. That all makes perfectly good sense. And so I don't know about the actual interventional since I'm not in the cath lab anymore, what they're looking like now. But I can tell you from the ultrasound, it looks a little different because a lot of these clots are more echogenic than I'm used to seeing. And you can see an echogenic clot again in a chronic clot, but I'm seeing more of it with an acute presentation, if that makes sense. I'm seeing kind of like a chronic looking clot, but with an acute presentation. And so I think that's another distinguishing feature that I'm picking up. So I think if you would like me to, I think we're ready to share.
If you can share, try and share your image. Just click on present, and then you can choose to share the window or the screen. You could do either.
Do you see that?
While he's doing that, I just wanted to add something.
Yeah.
When you get deposition on the vessel wall, you'll see narrowing on an angiogram. But when you got a piece of tissue, like a little fiber stretching out into the lumen, flapping around, you won't see that on an angiogram.
Yeah.
Right? Because the contrast runs past it. You don't see a difference in the vessel wall. But what we might see is if this gets large enough, then it might give you turbulence enough to create murmur, like a heart valve would.
You mean a flow? So you're using the ultra, because this is the question that I wanted to ask Philip.
How do we pick them up?
Yeah, because if you're right and you're seeing the turbulence, because you should be able to pick that up with Doppler flow, where you would see this change in the flow of the blood through a region, kind of like what we would see in the carotid arteries and so on. The problem is how would you make because the question people ask is this: it's all well and good us talking about this and raising awareness of it, but how do we know who is affected? how could we screen to identify the people who are affected and therefore know who to target in terms of therapy and how to monitor them? This is really fundamentally the question. And you
Yeah.
need to be doing something that is largely non invasive, meaning that you don't want it to be angiograms because it's giving contrast. And so it would be probably more likely best to be Dopplers. But if you're doing Dopplers, you're limited to which blood vessels you can look at, unless we have a different technology. Maybe MRI is, but then the time and you need it to be simple, that you're able to screen very quickly whether or not this process could be occurring in someone, and then that person would almost be referred for further investigations and therapy. And any thoughts on that, Philip?
Yeah, absolutely. I think that's a great start, and that's what we started to do early in the pandemic. And I think that we probably should revisit that and just a simple Doppler ultrasound. However, unfortunately, some of these clots will start in the pelvis. Okay, and when they're in the iliac veins in the pelvis, we're not very good typically at picking those up. And when a clinician orders a study to look at clots in the leg, it will be the leg. Then they'll stop at the common femoral vein, which is right before the pelvic vein. So we're not even looking at them. So we'll miss those. And that's a issue because, then unless you're only as good as your technologist when it comes to ultrasound. And unfortunately, if you have a weaker technologist that is not savvy enough to deal with the pelvic structures, and again, you got bowel gas down there and other things that get in the way, and a lot of times you just can't see it. So you could start off with a Doppler ultrasound, and then if there's a high suspicion, then I would probably move to either MRV, which is a magnetic resonant venography, or CTV, which is a CAT scan venography. Those would be a little bit more detailed and a little, but yeah, I think screening and just the extremities to start with. And again, not only am I seeing clot in the extremities, I'm seeing clot in the lower extremities, in the upper extremities. So I'm seeing them in both places. And it's not just limited just to your lower extremities, but the pelvis is a problem because we're missing a lot in the pelvis, just because we're not looking. So
Yeah, so it really, this is the point, is that people, I keep on emphasizing that at the end of the day, whilst there may be political arguments about who is responsible and if this is right, this is wrong, I have found that too many people are too focused on the right and wrong and not focused on solutions. Because at the end of the day, we need the solutions. Because even if the medical fraternity came out in the next week and said, you know what, this is serious, let's investigate it, let's try and work it out, they would still need to figure out how to identify the people at highest risk, because that's how medicine works. You want to find the highest risk people, you want to mitigate their risk, and you want to be able to monitor to see whether or not your strategy is working. And so we need at least 3 or 4 different layers that have to be done at a broad population level. So this is the other thing, is that the experience needed with ultrasound, you will not have enough sonographers to be able to do this. Will you need to use artificial intelligence? It's all kinds of questions that need to come out of this. And we are so far behind the curve at this point because we ignored it for what, 2 years?
Going
at
on 3.
least, yeah, at least 2 years, 3 years. Well, we're
Yeah.
having trouble. The file says it's too big to share, but I wish I could show you this
Well,
stuff.
what you do, one last try is don't share the file. Open the PowerPoint and share your screen.
Can you
Okay,
do
so
that?
just open the PowerPoint, and when you click on present, just share screen.
Okay. He said, just open my screen and go to my PowerPoint and that's what happens when you're 60 years old and you've always relied on your children to do your technology for you.
Ah, yes, yes. Don't worry. In time, you'll have an artificial intelligence person standing there and just, you tell it what you want, it will just put it up immediately. But yes, Shankara. So we are talking about this in the context of first world countries. What would happen in areas where you have limited resources? Granted, they have less of an issue because of the fact that if this is connected with the elephant in the room, they're less elephantized. But
Yeah,
if
yeah, yeah.
they did have the problem,
You just put it on my
what
screen.
could be done that would be practical?
Yeah, I think, Philip, we need to find the hope. So we got to figure out how to diagnose people earlier, how to, if we can figure that out, prophylactically, what do we do to prevent them from forming? Uh, Clearly, these clots occur in areas of the body where traditional clots never occurred before. So there is definitely a triggering event that creates these clots in these unusual destinations. And yeah, so I think the understanding comes from the lipid nanotechnology, how they actually triggering this nidus and causing the problem. And you see, that's a difficult thing, Philip, because if you want to address the true issues, then you're going to have to address the technology and the poor the poor way the technology works. So the lipid nanoparticles, messenger RNA or modified RNA, the uridination of terminal ends of it to keep the longevity, whether lipid technology should be used in the first place with its biodistribution. All these questions come into play. And these are questions that the people that are making the money out of messenger RNA technology, using it for everything that they can, are not going to be happy with. So it boils right down to the toxic nature of the technology. And nobody wants to admit to that because they looked at this as their new cash cow.
I agree with
Now
that.
we have to slaughter that cow or that elephant.
Yeah, so this is where I think that and this is the bit that I think people struggle to grasp when, so say for instance, when Gert has been saying about what's coming, when I look at where we are now and I think about patients, so many people are so sick, you know. I don't this is, I don't know if there's anything we can do for some people at this point, even if we understood it. I think that it may be too far gone for a percentage, for a bit of the population. And even that we need to figure out. Kind of like what happens, what we know, for instance, with cancer. If you see somebody who has got metastatic disease, you pretty well know that it's going to be difficult, unless it's a very specific chemotherapy responsive tumor, that you're not going to cure them. And so, in the same way, we would need to have an understanding as to who would benefit from therapy at what point. I mean, this is a huge, huge issue that, even with the best will in the world, will take us years to figure out.
That's Philip. I think, notwithstanding the fact that there's clear obfuscation of scientific research that will get us there quickly. And it's one thing understanding the problem, it's another thing having your hands tied behind your back when you try to treat it. So the problem is not just the understanding, the problem is also the latitude doctors are allowed in actually trying to address the problem out of the box. Because I can tell you now, the normal in the box solutions aren't going to work because we're dealing with an out of the box kind of problem. And so the
Absolutely.
pharmaceutical industry is going to push traditional medicines and they're going to have failures and they really don't care if it fails. So what are we going to do? Be picking up the pieces of all these misdemeanors. So I
Yeah,
think, yeah, people need to stand up.
yeah,
And I
absolutely.
think as well,
I mean,
patients must take responsibility.
yeah, we are so captured by the pharmaceutical industry, until we break through that, I don't think there's a whole lot of hope, uh, except for what I would say on a grassroots effort, like people like yourself and the Merricks and the McCulloughs of the world, and because it's just too controlled by pharma, and with the in all of our specialties. My cardiologist colleague was telling me just the other day that they have to pay now to get their journal. So when have you ever had to pay to get a journal? I mean, it's just gone. I don't know. We're just in a very dark time when it comes to our medical field, and what's transpired. And it's all about the money, and it's all about the control from basically pharma. And you and I know a different level, even above pharma, but I don't need to talk about that, but there's something bigger in control. And I try to stay out of that cloud because we're already crazy enough and we're already the fringe doctor. So I just wait till somebody asks me the question, then I'll say, well, let me explain really why we're here. But so we are not having success at all, and I'm very disappointed because I wanted to show you.
I'm sure we'll have other opportunities. I think that, don't worry, let's focus on, because we almost at the hour mark anyway. So
Okay.
I want us to focus on at the end what we think can be done that is different, because as I said, no matter, even if we started now with everything at our disposal and the full medical community suddenly realizing and getting on board, we're still years behind the curve to find solutions and to find ways of mitigating this. But the duty of candor that we should have as professionals should force us to acknowledge that error and be able to say, listen, we should have done better. Do you ever think the medical community would do something like that?
In my opinion, no. I think I think we're making little bitty headways now, but I think that's part of a plan of something else to come. And I don't want to go down that route, but I just don't see us, as long as we're controlled by pharma, I do not see that happening, because there's got to be a profit in it for them. And until things change and until they get responsibility and liability for what they've done, and it comes back on their shoulders, I see it a very difficult time getting to what you're talking about. Now, if that changes, liability issues and responsibilities, absolutely. I never give up hope. I mean, and there's, doctors all around the world like Dr. Chitty, that I'll never give up hope and I'll never stop fighting. But as the system sits as it is, very difficult. That's my opinion.
Shankara?
Yeah, Philip, I think a few things need to happen. One, let's stop causing the problem. So we know what the problem is. So let's stop creating more of the problem. Stop distributing those elephants. The second thing we need to do is the public needs to understand that they were coerced. You asked me this question once before: how do we restore faith in the medical fraternity? I think my answer was, you can't restore faith in someone that tried to kill you. And so where we sit right now is to redefine who the true medical fraternity actually is. It's not this it's not this private club that's run on egos. So I think we need to redefine what a medical fraternity is. The three of us here today are fighting for the survival of the medical fraternity. The people in the medical fraternity are not, because look at the definition, we are fighting for our patients. And then when it comes to the doctors, the medical fraternity itself, if they don't get on board and start to look at the issues that we have, we got a rough road ahead. But people like us, who have been trying to figure out the problems, need to stand up. And of course, the general public needs to take responsibility for the injuries that they have. It's none of us that have caused these injuries, but we're the ones stepping up to the plate to try and treat it. So I think people need to know their place, know their lane, take responsibility for the actions you've taken. Whoever has coerced you into taking those actions, they are responsible for it. I see patients, Philip, they're severely vaccine injured and they expect a miracle. But they've given their doctor 2 years of leeway to try and treat them, and he's failed. And then they come to me and expect a miracle simply because I've spoken out against the vaccine from day one. So yeah, I'm very straightforward in the way things are done. And now those companies that mandated the vaccine for their employees are now sending those very same employees to me to get medical certificates that they fit for work. Why would that be? What have you done to them that might make them unfit? So I examine them and I give them a full medical certificate to say that they're fit for work. But I end it by saying they have, however, been vaccinated 3 times with this vaccine, so that the liability of that choice to take a vaccine leads to me not being able to give you a full medical fitness. So be it. I can't put my head in the block for someone that's done something that I'm unaware of the repercussions of.
Right.
So,
And
yeah. We want hope, but we gotta accept the situation.
And speaking of patient responsibility, of course, I think that they're persuaded into this false sense of the shots being effective. And so they're so heavily weighted on the medical community, you can't blame them to an extent. But I will give you an example that I have a case that I was going to show you. It's a gentleman who is 68 years old. I read his CT scan in 2016. He had a renal cell carcinoma. He had a partial nephrectomy. Part of his kidney was removed, and vaccinated, boosted, and develops recurrent renal cell carcinoma 6 years later. Perfectly fine before that. The tumor was so massive, it was an 8 to 9 hour operation. He had a 1% chance of surviving that. And on my slides, I put in one for good luck. And the reason why I said one for good luck, and he has been educated many times about the injections, and he went and got another injection after his surgery, after he survived it. And so sometimes you cannot help that train of thought. And I don't know how to get through to some of these people. It's just very difficult because they still, unfortunately, think that really, I mean, even though things are changing and the numbers have decreased, I still think they, in the back of their minds, believe that we're probably on the wrong side of history for now. Unfortunately, that's the way I feel. I mean, that's just dealing with friends and family and patients. And the patients that seek my help, of course not, but people that are really kind of set in that medical community and believe in the old system. It's kind of hard to break through to those guys. So,
and I think Shankara, you alluded to it. As we come to the end, I'll ask you guys to do your tie-up words after this. But here's the important point that Shankara mentioned, Philip just mentioned as well. Nothing changes if the public don't act on it, if they don't apply the pressure. And at the moment, there is no urgency either from political leadership. You can see what's happening in the UK with excess deaths. The politicians feel that they don't need to because their constituents are not pressuring them. And so, therefore, at the end of the day, everybody has to take responsibility for their voice. And if your voice, not talking about we're clinicians, we're talking about it, but it's not just the doctors and the scientists and the politicians who have a voice. Everybody has a voice. And it is incumbent on everybody to ask questions. If you don't ask questions, you're guaranteed that no answers will come. And that's where I think we are at the moment, is that all we can do is raise the point. And remember this, nobody can conclusively say what is the cause. What we can conclusively say is that it has not been thoroughly investigated. That's the most important, fundamental point. You can't say that we don't know if you haven't done adequate, thorough, complete investigations, which have not been done. And that kind of pressure has to come from the public. It's not from the doctors who people consider to be fringe. The public needs to demand advocating for their family, friends, loved ones who have already succumbed. You need to do it for them and for yourselves. That's the truth. So, final words, gentlemen. Philip, you want to go first?
Yeah, I agree with you, but I also agree that I also believe that we do know where this is coming from because it started after something was starting to be administered. Now, however, I don't know the process. We need to understand that process better so we can treat it better. Okay, so in that respect, I disagree a little bit because before these elephants, as you called them, were administered, we did not have this problem or the amount. So I think we do know what the issue is. We don't understand it. Like you said, we don't know the physiology behind it, and we don't therefore know how to 100% treat it. So I think that's important. But I also end with this to whoever I'm speaking to, that God gave us this great immune system. We've been here for thousands of years, and we will overcome this. We will eventually figure out a way to treat it. It may take a long time, but we will never give up, and we will continue to fight. As long as evil's on the earth, we will fight it, and we will figure it a way out. So there's never give up hope.
Excellent. Shankara?
Yeah, I think, Philip, there were mistakes made. And I think I said this before, there's only two boxes in this church, a confessional and a coffin. So at the end of the day, we better confess if we've made a mistake. And I think even the vaccine manufacturer has come out and said that his vaccine was never tested for safety and efficacy. And he himself has confessed that it was had a lot of side effects. So I don't want the public to believe me. Public must believe the manufacturer of their vaccine, their holy vaccine. And so at the end of the day, I think at the bottom line is to accept and acknowledge that there is a problem first and foremost before we can go ahead and actually try and address the problem. So yeah, I think it's for people to realize that, yeah, mistakes were made and we got to figure out how to address those mistakes. But there's always hope. The hope comes with confessing. You can't have retribution without that. So yeah, we made a huge mistake. The people that are on the side where they want to keep doing this with the vaccines and things, we can't change that. Now, I'm asking the public to accept that they've made a mistake, but it's not only the public I ask that from. It's also in the future I'm going to have to ask a vaccinated judge to actually make a ruling that he's made a mistake to acquit me from my case. So I think the prejudice around what has happened has divided society more than anyone could ever understand. The entire judicial system of the planet has been divided on a vaccine status. And we're never going to get any fair judgments moving on. So we got a very difficult road ahead. But it gives us, the unvaccinated, a chance to reform and reset in a more equitable way.
Excellent. Excellent.
Philip, can I ask one quick question to Dr. Chetty?
Yes, go ahead.
All right, early on, I believe it was you that I've used this study. Did you treat a lot of people with like 12 milligrams a day with a certain medication? Was that your protocol?
Partly, yeah.
Yeah.
I actually started that with my vet.
Okay,
He
and
gave me the advice
it was a 12 milligram, correct? Is that right?
Exactly.
Yeah, I use that. I use that a lot of times, and I couldn't remember because I was looking at so much information when all this was coming out, and I said that I'm gonna try that, and I stayed at that level, and I did great. My oldest patient was 103, and they all survived. Nobody died. I actually took people out of hospitals and treated them, and they did fine. So anyway, it's a pleasure meeting you guys.
Wonderful. And I'm sure we'll have a chance, Philip, to go through those slides. And
really, I think y'all would be, it kind of hits home so you can actually see the pathology as in a person that's still alive. And anyway, and seeing what I'm seeing every day at the board, every single day, there's something. I take a picture of it and record it. So
excellent.
Anyway.
So thank you very much, gentlemen. Thank you, audience, for being with us, and look forward for more presentations in the future. Gentlemen, can you stay with me for the next few minutes just for the outro? Have a great evening, everyone.